my presentation is largely about NORC's capacity to quickly mobilize at scale to address a enormous public need, especially from an information technology perspective, by using, in this case, infrastructure that we've developed for AmeriSpeak and also Foresight 50+, using pre-recruited households, otherwise known as panels. Next slide, please. And of the dozens of studies that we did on AmeriSpeak in the last year and a half related to COVID issues, we selected 2 project case studies today to share with you. I will be giving you also some research findings, but being primarily a sampling and methodologist, survey research expert, I think I'll probably emphasize methods a little more than the findings. But please do feel free to look up these studies yourself to burrow into the findings. The first case study involves mental health in COVID times. If you can go back 1 slide, please. And the mental health and COVID time slide project was selected largely so that we could demonstrate the Foresight 50+ capability, which we rolled out earlier this year to the public. And the second case study on the right involves our sponsors at the Centers for Disease Control and Prevention, specifically the National Center for Health Statistics, using their RANDS program. It's the Research and Development Survey arm that tests various question wording experiments related to the National Health Interview Survey. Okay, next slide, please. And we'll move on to the next slide, which is more substantive. So related to the mental health study for AARP, the first question is why? Why was the research done? And AARP, as you probably know, is a mission-driven, not-for-profit membership organization dedicated to improving the lives and well-being of all Americans, but particularly persons age 50 and older. So we have tremendous mission alignment between our 2 organizations with respect to NORC's goals as well for informing decisions that ultimately will benefit all Americans and their well-being. So in this case, AARP was quite concerned about the pandemic's impact on the mental health of older Americans. And at the time, we were developing, and if you can move to the next slide, something that we call Foresight 50+. And this has been a couple of years in the making. And essentially, it's AARP and NORC forming a partnership to create first-class, scientifically rigorous survey research infrastructure so that organizations of all types, whether it's consumer-oriented market research or public policy-driven surveys, or surveys like this one, looking at the mental health impacts from COVID-19, regardless of the topic, we saw a need to step in and develop a nationally representative panel of pre-recruited households with people aged 50 and older that could be used for quick response surveys, academic research, et cetera. And that's what we've done. We launched it last June, and it's an ongoing concern now. Moving on to the next slide, what we get to now is about Foresight 50+ in terms of sample representativeness and response rate enhancement. And we did want to make everyone aware that the underlying sample does use extensive refusal conversion as part of the process of building this panel of households. So when I say 2-stage recruitment here, I want to be clear that we're talking about the recruitment of the households in terms of enrolling them into the panel. I am not talking about the actual methodology of conducting client-driven surveys. The client-driven surveys are primarily online and telephone mode surveys. But in building the panel itself, we feel very strongly that we need to do that face-to-face, in-person field recruitment to make the refusal conversion really work. And we see that particularly with low-income households, lesser educated households, households comprised mostly of Spanish language dominant individuals. These are all segments of our society that are typically hard to reach for empanelment and surveys, and hence we resort to the extensive face-to-face recruitment to assure that we have adequate sample representation for those segments of our society. Okay, moving on to the next slide. So about the survey itself that we did here, we used the Foresight 50 Plus Omnibus product. We have monthly a survey that is a multi-client vehicle that focuses on the persons age 50 and older that make up our Foresight 50 Plus panel. And typically this Omnibus survey might have 4 to 5 different batteries of questions. So one battery from one particular client and then another battery from another client. And we use it in this case for an AARP commissioned research that NORC was happy to take on. Our measures you can see in the middle column there are the ones that you might expect. We really focused on loneliness and anxiety measures. We did have a question in there about mental health care use. To be clear, these are all self-reported measures. There's no attempt to look at administrative records or provider records. This is simply a self-report survey. And we looked at diet and a few other measures. In terms of the details of the survey itself, the Foresight 50 Plus Omnibus typically has about 1,000 interviews in it, which we did for this. And we also conducted the survey both online and phone back in April. And as you can see, it's a very short turnaround. It's only about a 4-day field period because our goal is to be able to give our clients data back and findings within 2 weeks. So the whole project takes 2 weeks or less. All right, moving on to the next slide. This is the findings slide. I do encourage everyone to just simply, if you Google the AARP COVID mental health study, you'll see the more extensive findings. But essentially, we found out that we were all justified in our worry about the mental health of persons age 50 and older as a result of COVID. And particularly if you look at the mental health measures, 7 out of 10 self-reported an increase in sadness or depression that they attributed to the pandemic. Similar measures in terms of worrying about the future. So the outlook questions consistently showed increases in worry and loneliness. The socializing stat there you see of 62% self-reported socializing less. That's not surprising given the isolation, but it's more confirmatory and corroborating, I think, what a lot of us feel is the case for all Americans, but particularly people age 50 and older that were more susceptible and persistent, remaining more susceptible to this illness. Depending upon your outlook on life, the 27% number on seeking spirituality may be refreshing or not. It may be an indication of the worry level, or it could mean that people are, literally trying and are inspired to have more depth in their way of thinking about life. So those were a few of the highlights. And if you go to the next slide, just as a reminder, in terms of the Foresight 50 Plus Omnibus, we encourage its use for multiple purposes. It doesn't always have to be, relatively high-minded academic research or public policy driven. We do encourage consumer market research studies on it, because our feeling is that well-done consumer market research studies of this population can help with product development and improvement of services that benefit persons age 50 and older. Okay, so we'll move on to the second case study, and I'll be happy to take any questions that you have later about the first case study. So this is the RANDS project that we conducted for the CDC and NCHS. Next slide, please. And why did NCHS come to NORC for this work? Essentially, we had a contract in place already with NORC's AmeriSpeak unit conducting surveys for the RANDS initiative. And in this case, with the onset of COVID, there was interest in conducting a large sample size survey in a very timely way to measure a few issues. And I list the issues here, and I'm going to come back to them later with some selected findings. So we were happy to take on the work. The real challenge to this project is we needed relatively large sample sizes in order to pull off the statistical precision needs. And if you move to the next slide, you'll start seeing how we pulled that off. Essentially, what we did was use our AmeriSpeak panel sample, which is probability-based, nationally representative, has the highest response rate at the panel recruitment stage of commercially available panels in the US And that is attributable, of course, to our face-to-face refusal conversion work we do with NORC field interviewers. We combine the AmeriSpeak sample with the non-probability opt-in samples, which are commercially available. And I think many of you probably use these non-probability samples. Our point of distinction here is that we have developed a calibration weighting routine, which we call True North. And that True North weighting routine allows us to make best efforts to reduce the error that's being introduced by using the non-probability opt-in samples. Many of you probably know that the non-probability samples tend to have predictable error in the self-report of behavior, of knowledge and awareness. So a typical knowledge, attitudes, and behavior survey on a non-probability panel will tend to give you higher measures than on a properly selected probability panel. So we developed this calibration weighting routine and applied it for this project. And by moving to the next slide, I can show you a little bit more how that worked. If you look at the left column there, essentially we used the AmeriSpeak part of the sample for the longitudinal two-wave survey. We felt it was very important to have a relatively large sample size at baseline. And as you can see, we had almost 7,000 interviews with general population adults at baseline on AmeriSpeak. And then about 6 to 8 weeks later, we did a recontact, re-interview study with that sample and had almost 6,000 successful completions among the baseline. So we have a relatively large two-wave survey sample size for analysis there on COVID-related behaviors that NCHS was very interested in. But we wanted to be able to have the statistical precision to really drill into some very specific subpopulations. So for that purpose, for the baseline survey and the first follow-up, we did supplement the AmeriSpeak sample with approximately 6,000 interviews each time from the non-probability surveys. So for the cross-sectional part of the analyses, we did have available to us almost 12,000 interviews for the June and July baseline. And then for that first follow-up period, you see in August 2020, we did have about another 5,500 interviews for the non-probability. So that gave us a lot of statistical precision. And for the cross-sectional surveys, we, of course, used our calibration weighting routine that I briefly mentioned. Okay, next slide. So I have 3 finding slides here. These are slides that are taken straight from the NCHS RANS data tool. So they have on the website a pivot table that you can use. So you can select whatever measures you're interested in and cross them with various demographics and socioeconomic characteristics, et cetera. This first one I thought was interesting because of the explicit measurement about the previous week of individuals being unable to work because either they themselves were ill from COVID or a family member was ill. And the numbers are small. You can see the 2% number for the age 18 to 44 group, but just recall that that's on a per week basis. It's looking at the previous week only. And the call out for me is that by having the relatively large sample sizes, we're able to reduce our standard errors here quite a bit and have some confidence that we were seeing some real differences here across the subgroups. Okay, next slide, please. And then the next question is about telemedicine. I think what's interesting for me about this is still the relatively low levels of self-reported access to telemedicine. You can see that the number is hovering between 30 and some 45% of individuals reporting that they had access to a provider that is engaged to with telemedicine. I think the other finding there is just looking at the 65 and older group being more aware, maybe they're more motivated to seek out telemedicine and hence more aware that their provider has this capability. And then finally, on the last slide, I wanted to just share with you the information about individuals that were unable to receive a regular checkup in the last 2 months. So these are individuals that sought a regular checkup, but were unable to do so. And again, because of the relatively large sample sizes here, we're able to detect some trends here. Very early in the pandemic, if you look at the black bar on the left side there, you'll see that the lack of access percentage is slightly higher, and there's a directional trend in a positive direction, actually. So just actually access is slightly improving as time moves on. So that was an encouraging trend, but I think it does show that early in the pandemic that perhaps our providers were overwhelmed and that there was a spike in terms of lack of access to regular care. So that concludes my findings and my presentation as a whole. Thank you.